disorders. And how many minutes do we have? 1 hour or 1 hour 30 minutes?
Almost 1 hour 30 minutes.
Okay, that's good.
Including Q&A session.
Okay. So here are some learning objectives of today's presentation. So we will try to identify a patient of endocrine and metabolic disorders based on diagnostic criteria and classification. And we will try to classify the patient based on some classification criteria. So I will give you some of the tips how we can diagnose a patient of endocrine and metabolic disorders. And mainly we will discuss thyroid disorders, diabetes, and obesity. So these would be our focus. Just give me a minute. So the second learning objective is to review therapeutic agents which are used for the management of endocrine and metabolic disorders. And we are talking here about thyroid disorders, diabetes, and obesity. And we will compare and contrast different treatment options available for the given patient of thyroid disorders and diabetes. We will try to select appropriate treatment option and ways to monitor the outcome of the treatment according to the established practice guidelines. And we will also learn to recommend management to avoid long-term complication of diabetes. So as I already told you, the presentation focus is thyroid disorders, in which we will discuss hypothyroidism and hyperthyroidism. We will talk shortly about adrenal disorders, mainly Cushing's disease, and diabetes, mellitus, and obesity. So let's start from thyroid disorders. So thyroid, as you already know, that is under the control of pituitary, and pituitary is under the control of hypothalamus. So pituitary is the master gland and hypothalamus is the master of the master. So hypothalamus releases thyrotropin releasing hormone, which stimulates pituitary, and pituitary then releases thyroid stimulating hormone, which has a receptor on thyroid gland, and thyroid then releases thyroid hormones, mainly T3 and T4. And as you can see here, there is a negative feedback between thyroid hormones and thyroid stimulating hormone and thyrotropin releasing hormone. What does it mean? That whenever T3 and T4 levels are increased, for example, there would be a negative feedback effect on the pituitary, and pituitary will decrease the secretion of thyroid stimulating hormone. So in this negative feedback effect is, important to understand, because it will serve in the diagnosis of either hyperthyroidism or hypothyroidism, as we will see shortly. So thyroid disorders, we will talk about pathophysiology now. In hyperthyroidic states, the most common disease is Graves' disease, and it is an autoimmune disorder in which antibodies are formed in the body, which stimulate thyrotropin receptors on thyroid gland. So whenever these receptors are stimulated, obviously thyroid gland will release thyroid hormones, irrespective of this, that these receptors are not actually stimulated by thyrotropin, but these receptors are stimulated by antibodies which the immune system has generated against these receptors. So this Graves' disease is not the only hyperthyroid state. We have other diseases of the thyroid as well. For example, there may be thyroid stimulating hormone secretory tumors of the pituitary. So that means the pituitary is secreting, due to the tumor, a lot of thyroid stimulating hormone, and that thyroid stimulating hormone will definitely affect thyroid gland to increase the secretion of T3 and T4. We have autonomous thyroid nodules, which is also called toxic adenoma. We could have multinodular goiter, thyroiditis, or drug-induced increased secretion of thyroid hormones. So all of these could result in hyperthyroid states, but the most common one is Graves' disease, and we will discuss mostly the Graves' disease here. On the other side, in cases of hypothyroid state, the most common state is Hashimoto disease, which is also an autoimmune mediated disease. But in this one, the immune system generate antibodies against the thyroid itself. So actually the antibodies, they destroy the thyroid gland, and the ability of the thyroid gland to secrete T3 and T4 decreases. So that's why there is deficiency of thyroid hormones. So there could be also other states which result in hypothyroidism. For example, surgery or ablative therapy, which has been performed on a patient of hyperthyroidism, can result in hypothyroidism. Okay, so a patient came with hyperthyroidism, and I mean the physician or they performed a surgery or ablative therapy, but because now the thyroid gland is gone, the patient may go into a hypothyroid state. Similarly, iodine deficiency can cause hypothyroid states. Pituitary insufficiency, where pituitary is unable to secrete thyroid stimulating hormone, could also result in hypothyroidism. And drugs like lithium can also induce hypothyroidism. So we will not discuss every type of hypothyroidism. We will only discuss the most common one, which is the Hashimoto disease. So let's see the clinical presentation of both hyperthyroidism and hypothyroidism side by side, because you will see that most of the signs and symptoms, they are exactly opposite to one another. For example, in hyperthyroid state is like all the metabolism of the body is increased. So you will see that every clinical presentation here is a result of increased metabolism. For example, weight loss, heat intolerance, warm and moist skin, fine hair on the body, increased bowel movements, palpitations, tachycardia, anxiety, nervousness, insomnia, exophthalmos, and thyromegaly. So all of these, as you can see in hyperthyroidism, all of these are clinical presentation of hyperthyroidism, and you can identify a patient based on these signs and symptoms. On the opposite side, if you see hypothyroidism, they are almost opposite of it. So there is weight gain in hypothyroidism. So in hyperthyroidism, there was weight loss, but in hypothyroidism, there is weight gain. Similarly, in hypothyroidism, we have cold intolerance, cold, dry skin, coarse hair, decreased bowel movements, bradycardia, depression, lethargy, and fatigue, and preorbital puffiness. So why this is important to see hyperthyroid clinical presentation and hypothyroid clinical presentation is because, as we already discussed, that when you treat a patient for hyperthyroidism, the patient can undergo in hypothyroidism, because you are trying to target decreased secretion of thyroid gland. So when you treat the secretions of thyroid gland, the patient may undergo in hypothyroidism. Uh, Same is true for hypothyroidism treatment, because you are trying to increase the secretion of thyroid gland with the help of medicine. So the patient could undergo in hyperthyroid states. So you should be able to identify the patient based on these signs and symptoms, whether the patient is undergoing hypothyroidism or hyperthyroidism. So this is the I have put a lot of cases in my presentation. Most of these cases are also included in the workbook, which you can get from your mentors. And some of these cases are from the past papers. So definitely they would help you to prepare for your exam. So after the presentation of each case, we will pause for a few seconds, maybe 15 to 20 seconds, and you can write your answer in the chat box. Not for everyone, you can send your answer to maybe the moderator of the session, which is Rida, I think. So you can send your responses to her, and then we will tell you the answer as well, and we will discuss why this is the most appropriate answer. So you can see here there is a patient which is 38 years old, school teacher, who present to the clinic today with noticeable dark circles under her eyes. She has difficulty with sleep. So this is first of the sign, which is insomnia, mainly with staying asleep. It takes her about 20 minutes to fall asleep, but after about 2 hours, she wakes up and cannot fall asleep again for several hours. She took diphenhydramine for sleep. So this is one of the over-the-counter for sleep, but didn't continue due to drowsiness in the morning. Her other medical problems, including hypothyroidism. So you see, she is a known patient of hypothyroidism, and she was taking levothyroxine 125 microgram at bedtime for her hypothyroidism, or for his hypothyroidism. He or she has hypertension, for which the patient is taking hydrochlorothiazide 25 milligram in the morning, chronic back pain, for which the patient is taking ibuprofen, and the patient has depression, for which the patient is taking citalopram 20 mg in the morning. Which agent is most likely contributing to insomnia? So you can see here is a list of medications, and each medication is for different indication, but one of these medications is causing insomnia in the patient. So what do you think, which of the medications could cause insomnia? So we will pause for a while and then we will discuss. I cannot see your responses, but I assume that you have come up with the right answer, which is levothyroxine. So why levothyroxine? Because we already discussed that when you treat a patient for hypothyroidism, the patient can undergo in hyperthyroid state. So insomnia is actually a sign of hyperthyroid state. So because the patient is taking levothyroxine for hypothyroidism, the patient is going towards hyperthyroidism, and insomnia is going to develop in this patient. So levothyroxine is the correct option for this case. So let's go after a clinical presentation to the diagnosis of hyperthyroid and hypothyroid state. So we will discuss both of these states side by side. So you can see here that in hyperthyroid state, the T3 and T4 levels, they are raised. Okay, and when T3 and T4 levels they raise, we already discussed that there is a feedback that pituitary gland decreases the secretion of thyroid stimulating hormone. So you will see a decrease in thyroid stimulating hormone. So from this you can have an idea about the diagnosis, whether this is a hyperthyroid state or hypothyroid state, that the free T4 and total T4 levels, they will raise, and thyroid stimulating hormone that would reduce because of the feedback mechanism. But keep in mind that thyroid stimulating hormone will not reduce if the primary cause is in the pituitary gland. Okay, so in that case, you will see that thyroid stimulating hormone would be raised because pituitary is releasing a lot of thyroid stimulating hormone. So you will only see a decrease in thyroid stimulating hormone if the hyperthyroid state is because of the primary thyroid disease, not due to the tumor in the pituitary. Opposite to this, we can see in hypothyroid state, there are decreased levels of total T4, free T4, and total T3. And as a feedback mechanism, the pituitary releases more of thyroid stimulating hormone. So you will see increased thyroid stimulating hormones in hypothyroid in the patients of, for example, Hashimoto disease, which is a hypothyroid state. So what are the goals of treatment in these patients? So first thing, we have to eliminate or normalize excess thyroid hormone. Then minimize or eliminate symptoms and long-term consequences. So we will see that some of the medications which we use in thyroid disorders, they are not actually eliminating or normalizing thyroid hormone, but they are actually prescribed to counter the symptoms and long-term consequences of the disease. So keep in mind that in thyroid, we not only taking medicines to normalize thyroid hormone, but also to counter the symptoms. And also, one of the goals of treatment is to provide individualized therapy based on the type and severity of disease, patient age and gender, because sometimes we have to make adjustments based on the age of the patient or the gender of the patient. Uh, then you have to also see whether there is any existence of non-thyroid conditions, because for example, some states like cardiovascular disorders, they could influence the therapy in thyroid disorder. So you should be aware of the history of the patient, whether there is any other non-thyroid condition in the patient or not. And obviously, you should have an idea about response to previous therapy if the patient is already taking some therapy for the thyroid disorders. So what was the response of the patient to the previous therapy? And based on that, you can uh, advise changes of the therapy based on the previous therapy. So how you will treat hyperthyroidism? The gold standard for hyperthyroidism is ablative therapy by radioactive iodine. So this is one of the uh, most effective treatment options in which uh, the thyroid is destroyed by radioactive iodine. And if the thyroid gland is not there, obviously the secretions of the thyroid gland would not be there. So this is how you can treat hyperthyroidism. But the problem is, as we already said, that you should be aware of the other conditions in the patient, for example, pregnancy, because pregnancy is an absolute contraindication for the use of radioactive iodine. So keep in mind that ablative therapy by radioactive iodine cannot be performed in a patient who is pregnant. Another option is surgery that is preferred over ablative therapy if the volume and weight of the gland is more than 80 grams and there is severe ophthalmopathy or lack of remission on antithyroid drug treatment. So surgery is another option. And pharmacotherapy that is available, but that is only reserved for patients who are awaiting for ablative therapy or surgery. So they are on the waiting list. Surgery has been planned to perform. They are waiting for their therapy or surgery. So they can take benefit from pharmacotherapy to deplete the stored hormone. Another option could be pharmacotherapy reservation is for the patients who are not a surgical or ablative candidate or who refuses. Sometimes patients, they refuse that they don't want to undergo surgery or they don't want to undergo ablative therapy. So in such patients can be managed by pharmacotherapy. And the third uh, uh, reservation is if ablative therapy or surgery fails to normalize thyroid function. So if even after ablative therapy or surgery, patient is not able to normalize the thyroid function, then pharmacotherapy could be an option. So, which drugs are available under pharmacotherapy of hyperthyroid states? Let's see. So, pharmacological therapy, the first options are methimazole and propylthiouracil. One of the important consideration when you are prescribing methimazole and propylthiouracil is that they take some time to produce maximum effects. So they will not show immediate effects. They will take some time, almost 4 to 6 weeks, because there are some reservoirs of the hormone already in the thyroid. So they stop the iodination and synthesis of new hormone, but if the hormone is already stored, because of the storage of the hormone already in the thyroid gland, it could take almost a month to show some effects. And there is some risk of serious hepatotoxicity. And that's why propyl thiouracil should not be considered as a first line therapy in adults or children. So the first line therapy is methimazole. Propyl thiouracil is reserved for some cases. And the first one is if the patient is in the first trimester of pregnancy. So in this condition, propyl thiouracil is preferable because the risk of methimazole-induced embryopathy is more than the propyl thiouracil-induced hepatotoxicity. So in this case, if the patient is pregnant and that is the first trimester of pregnancy, and you have to treat hyperthyroid state in the patient, you can prefer propyl thiouracil over methimazole. And if the patient is intolerant to methimazole, then definitely propyl thiouracil can be used. And in thyroid storm specifically, propyl thiouracil is more effective as a loading dose and a maintenance dose after that. So in these three states only, propyl thiouracil is preferable over methimazole. Otherwise, methimazole is the first is the drug of choice. So this is one of the concepts which has been tested again and again in the exam. So I have also included a case related to this. So keep in mind that when methimazole is preferred and when propyl thiouracil is preferred. So other than methimazole and propyl thiouracil, we have iodides available as well, and they block the thyroid hormone release and decreases size and vascularity of the gland. So iodides, they do not have any influence on the synthesis of the T3 and T4. They only block the release of thyroid hormone. And definitely, after some time, they would not be able to hold the release anymore, and T3 and T4 levels would start to rise again. So they are actually used to decrease the size and vascularity of the gland. For example, if the patient is undergoing surgery and the vascularity of the gland is high, then iodide can be used to decrease the vascularity and size of the gland, so the patient can undergo surgery. So the symptoms improvement after iodide treatment, they occur within 2 to 7 days, and hormone reduced for a few weeks. And short-term use, iodides are used for only short terms for 1 to 2 weeks only, because these are not the mainstream treatment. They are only used to decrease the size and vascularity of the glands before the patient undergoes surgery. So there are these iodides, they are used as adjunctive therapy. As I already said, these are not mainstream. They are used to prepare a patient for surgery. They are used to inhibit the thyroid hormone release in severely thyrotoxic patients. And they are used to inhibit thyroid hormone release after radioactive iodine therapy as well. So after iodides, we will come to some agents, specifically adrenergic blockers, which are used only for symptomatic relief in hyperthyroid states. So adrenergic blockers, they are used as adjunctive therapy to control symptoms. This is important, and this concept is also being tested in previous exams, and that which of the agents is used for controlling the symptoms, which are palpitations, anxiety, tremor, and heat tolerance in hyperthyroid patients. So in elderly with symptoms, heart rate more than 90 beats per minute, and if there is history of cardiovascular disease, these adrenergic blockers, specifically beta blockers, propranolol and metoprolol, they are used as an adjunctive therapy to control the symptoms. So let's come to the second case, 84-year-old woman. So you should, when you are attempting a question, you should consider particular attention to age of the patient and other comorbidities as well. So 84-year-old woman complains of feeling anxious and warm. So anxiety and warm, these are symptoms of hyperthyroid state. She refused to undergo ablative therapy. Thyroid stimulating hormone is 0.22, which is low. Free T4 is 3.2 nanogram per deciliter, which is high. And she is a known patient of Graves' disease. Diagnosis has been made. So which one of the following is the most appropriate initial option? So pay attention. We are talking about initial option in a patient who has refused to undergo ablative therapy. So ablative therapy is a gold standard, is a treatment of choice. But if the patient has refused to undergo ablative therapy, then we can have other options as well. So which of the following could be an appropriate initial option? So we discussed two mainstream drugs, methimazole and propylthiouracil. One is preferred over the other, and we discussed why. So in this patient, this is an old female, so there is no indication whether the patient is, there are no chances, many less chances to be pregnant in this age. But anyways, the treatment of choice here is methimazole. Another case, MS is a 60.
Sorry to interrupt, sir.
Yeah.
But are the questions or the responses visible to you in the chat box?
No,
Just
no,
need to
because
ask.
I am again, the problem is I am on the iPad and it's very difficult to see
Okay.
two screens at
Okay.
the same time. So I cannot
So
see.
it's all right.
Yeah, you can see the responses, right?
Yes, there are two responses by Somaya Zubair and Noria Akmal, that option D they are saying. And regarding the question, so I will read the questions in the last of the session then.
Okay, so another thing, after the question, I will ask you whether, just tell me whether the responses are, right or wrong on the majority, based on the majority of the responses. That's it.
All right.
So, okay, so there is another patient, 68 years old, woman with a history of angina and hypertension, and was recently received a diagnosis of Graves' disease. TSH is 0.2. She experiences fatigue, heat tolerance, sweating, and tachycardia. Initiation of which regimen is likely to reduce her symptoms? No, now you have to pay attention on a word, symptoms. So some symptoms, let's see the symptoms: fatigue, heat tolerance, sweating, tachycardia. So which of the following options most likely will reduce her symptoms? So propylthiouracil, methimazole, they would definitely reduce T3, T4 levels, but not reduce the symptoms. Lugol solution, we said this is not a mainstream treatment. This is used as an adjunctive, and it would be not an option as well. So propranolol is the right option. Okay, because we already discussed that adjunctive therapy, beta blockers, they are used to control the symptoms in hyperthyroid disease. So let's come to hypothyroidism, treatment of hypothyroidism. So the treatment of choice is levothyroxine. And there are many factors which, due to which this is a drug of choice. For example, this is chemically stable, relatively inexpensive. This is active when given orally, free of antigenicity. It has uniform potency. So all of these factors, they make levothyroxine a drug of choice. So other options which are available for the treatment of hypothyroidism, they have different problems. For example, some have problem with the chemical stability, some are relatively expensive, and for example, they have antigenicity problems, and they do not have uniform potency. So if we consider all of these factors, levothyroxine is the drug of choice. And average adult maintenance dose is 125 microgram per day. But keep in mind, this is very important, that patients who have long-standing disease and the patients who are old, you should reduce the dose. And for them, the adult maintenance dose on average is 50 microgram daily. And you have to wait at least 1 month to see if the dose is giving the effects or not, because we already said that whether you are treating hyperthyroidism or you are treating hypothyroidism, it would take some time. So just wait at least for 1 month, and if required, you can increase the dose. Similarly, older patients who have known cardiac disease as well. So in those patients, the starting dose is 25 microgram per day, and you can titrate upward in increments of 25 microgram at monthly intervals. Okay, again, wait for 1 month, and after that you can titrate again in the increments of 25 microgram. And this is because they have already a cardiac disease. They are old patients and they have cardiac disease, and we are treating hypothyroidism with levothyroxine, which is actually T4. This can increase the heart rate in the patient. This can increase the cardiac oxygen demand in the patient. So that's why you can see that in adverse effects, you can see that angina, myocardial infarction, hyperthyroidism, they are actually adverse effects of the medicine, because this can push the patient in hyperthyroid state because you are giving T4. So if you give too much of T4, the patient would definitely will undergo hyperthyroid state and will experience the same signs and symptoms. So let's come to this case 4, 63-year-old woman. She is hypothyroid. Recent TSH is 10.6. So TSH is high because of the feedback, and free T4 is 0.5 nanogram per deciliter. Complaints of dry skin and being run down. What is the best drug for initial treatment? So we already discussed that the drug of choice is, yes, Reda, I hope everyone has got it right. So the drug of choice for hypothyroid state is levothyroxine. So that's the straightforward question. There is another patient who has been recently initiated on thyroid replacement therapy to treat hypothyroidism. When would be the best time? So this is very important. When would be the best time to recommend checking thyroid lab studies to assess maximum effects for this therapy? So he is taking or she is taking therapy, but we already said that therapy takes some time to show effects. So what is the appropriate window in which we can check the labs to assess maximum effects of this therapy? Just give me a minute. I'm going to take some water and you can answer the question. Yes, so we said almost a month. They take almost a month to show effects. So the appropriate answer would be 4 to 6 weeks. Another case, 60 years old patient complaining of fatigue, gained about 3 to 4 kg in weight and suffers from depressed mood. So T4 is reduced and TSH mildly elevated. So definitely the patient has hypothyroidism because T4 is reduced, and as a feedback, TSH is mildly elevated. And also there is fatigue, there is weight gain, there is depressed mood. So we already saw these things in clinical presentation of hypothyroidism. So which of the following is an appropriate treatment? So there is a catch in this question. If you didn't see that thing, you can answer it wrong.
Most of the participants are saying option B.
Okay, levothyroxine, 50 microgram daily and monitoring every 4 to 6 weeks, or TSH after 4 to 6 weeks. That's correct, because the catch here is the age of the patient. The patient is old, so we cannot give him the dose for which is for average dose for an adult patient who is not old. So that was approximately 125 microgram daily. So we cannot give the same dose to this old patient. So for this, reduced dose is a better option, which is 50 microgram daily. So let's go quickly to adrenal gland disorders. We will just discuss briefly about Cushing disease, and that's it. We will then go to one of the most important topics in endocrine and metabolic disorders, which is diabetes. So in adrenal gland disorders, there could be hyperfunction of the adrenal gland, and there could be hypofunction of the adrenal gland. So hyperfunction means that the adrenal gland is producing too much of the secretions, and hypofunction means the adrenal gland is not producing sufficient secretions. So in hyperfunction states, there is cortisol overproduction, which is called Cushing syndrome. And there are two types of it, adrenocorticotropic hormone dependent, which is commonly known as Cushing's disease, and adrenocorticotropic hormone independent. So both of these adrenocorticotropic hormone dependent and adrenocorticotropic hormone independent, both are classified as Cushing syndrome, but only adrenocorticotropic hormone dependent disease is called Cushing disease. So keep in mind this. So what does it mean? Adrenocorticotropic hormone dependent means that the problem is in the secretion of adrenocorticotropic hormone. So there is too much secretion of adrenocorticotropic hormone from the pituitary, and that hormone is stimulating the adrenal gland to overproduce cortisol. So this is actually called Cushing disease. And adrenocortico, there is a mistake here. This is not ACHTH. This is ACTH, adrenocorticotropic hormone independent. That means the problem is not in the pituitary, but the problem is in the adrenal gland itself. For example, there is some tumor in the adrenal gland which is secreting a lot of cortisol. So that would be an adrenocorticotropic hormone independent hyperfunction, which is commonly known as Cushing syndrome. And there could be overproduction of aldosterone, because cortisol and aldosterone both are the secretions of different parts of the adrenal gland. So that state is hyperaldosteronism. And hypofunction, we are talking about primary hypofunction of the adrenal gland, that is that is known as Addison disease. So what is the presentation of Cushing disease? The person look like a cushion. Who have central obesity or facial rounding, peripheral obesity, fat accumulation. Patient has a lot of myopathies, osteoporosis, back pain, fractures, glucose intolerance, diabetes, and hypertension could arise in Cushing disease. So we are talking about Cushing disease only, which is adrenocorticotropic hormone dependent hyperfunction of the adrenal gland. So the treatment goal in Cushing disease is to limit morbidity and mortality and to return the patient to a normal functioning state by removing the source of hypercortisolism. So we want to decrease the secretion of cortisol so that the functional state could be restored. And we want to minimize pituitary or adrenal deficiencies as well. So in Cushing disease, the treatment of choice is surgical resection of offending tumor. So whatever the offender is, because of the offender, the secretion of adrenocorticotropic hormones are increasing. So we have to treat the source. We have to surgically remove the offending tumor. There are some pharmacotherapies as well for the patients who are not surgical candidates, or for the patients who are surgical candidates, but they need management before the surgery and as an adjunctive therapy in post-operative patients. And there are some agents which you just we will just discuss their names. So the first one, which blocks the production of cortisol, that is osilodrostat, which was approved in 2020. There are some agents which block the secretion from the pituitary, for example, pituitide. And there are some agents who, they block the production of steroids, for example, ketoconazole and etomidate. There are some agents who are cytotoxic for adrenal gland. So they destroy the cells in the adrenal gland itself, and that's how the secretions are reduced. For example, metotane. And some agents, they are glucocorticoid receptor blocking agents, which block the glucocorticoid receptor instead of decreasing the secretion of uh, cortisol. And they are preferred in patients who have type 2 diabetes or glucose intolerance. So we will quickly move to diabetes mellitus because we are short in time, and this is one of the important topics in endocrine and metabolic disorders. So diabetes mellitus. So let's classify and have a look on the pathophysiology of diabetes. I'm sure you are all aware of that. So type 1 diabetes, that occurs in 5 to 10% of the cases. This is also called, previously it was called as insulin dependent diabetes or juvenile onset diabetes, because the onset of this is in the early ages. So this is usually results from autoimmune destruction of the pancreatic beta cells, which are the source of insulin. So that's why there is an absolute deficiency of insulin in type 1 diabetes mellitus patients. The other type is type 2, which is most common in 90 to 95% of the cases, which was also previously called as insulin independent. But we will see that this is not actually completely insulin independent. We have to administer insulin in some cases as well. So there are multiple defects in type 2 diabetes. For example, there is problem of insulin secretion. So there is problem of reduced incretin effect. There is insulin resistance. There is excess glucagon secretion. And there is sodium glucose co-transporter to upregulation in the kidney. So the pathophysiology is not as simple as in type 1 diabetes mellitus. There are many different mechanisms which can affect either the secretion of insulin or the effect of insulin on the cells to uptake glucose. Then there are some other types, for example, gestational diabetes in pregnancy, maturity onset diabetes of the young, or MODY, or some medications, they can also increase the glucose concentration in the blood. So let's talk about diabetes, diagnosis of diabetes. So there we are talking mostly about the recommendations of American Diabetic Association. If we will discuss something otherwise, I will tell you. But these are all the guidelines and recommendations of American Diabetic Association. So criteria for diagnosis of diabetes mellitus include any one of the following. HbA1c levels more than or equal to 6.5%, fasting glucose more than or equal to 126 mg per deciliter, and oral glucose tolerance test more than 200 mg per deciliter. And what does we mean by oral glucose tolerance test? That 2 hours after 75 gram oral glucose, the glucose levels in the blood should be less than 200 mg per deciliter. And random plasma glucose, if that is more than or equal to 200 mg per deciliter, that with classic symptoms of hyperglycemia or hyperglycemic crisis, for example, polydipsia, polyuria, then that is also a criteria for the diagnosis of diabetes mellitus. But the last statement is very important, that the diagnosis requires 2 abnormal tests showing hyperglycemia and can be obtained from the same sample or 2 separate test samples. So only one criteria is not enough to diagnose diabetes mellitus. American Diabetes Association recommends that there should be at least 2 abnormal tests from 2 different categories, which I've mentioned above, and they can be obtained from the same sample, or they can be obtained from 2 separate samples. So this is one of the concepts which has been tested in one of the exams, that which test is required for a definitive diagnosis of diabetes mellitus. Yeah, so this is the case. This is also given in the workbook. There is a patient, 64-year-old African-American woman, 12 kg weight increase during the past year, primarily because of inactivity and a poor diet. So as you already know, that diabetes prevalence is increasing because of increase in diabetes. Increase in obesity and lack of activity and poor diet habits. So all of these risk factors are present here in this patient. Her BMI is 44 kg, too much. Her mother and sister both have type 2 diabetes, so there is familial history as well. Fasting glucose 212 mg per deciliter. Okay, so way more than the threshold we have described. Which is the best course of action? So should we diagnose type 2 diabetes and begin the treatment? Should we diagnose type 1 diabetes and begin the treatment? Should we obtain another glucose concentration today, or we should obtain an HbA1c today in addition to the glucose concentration? So what do you think? Yes, Rida, what most of the people are saying? No one is saying anything? Anyways, let's see what's the answer for this question. So we already discussed that American Diabetes Association that recommends that at least there should be.
Yeah, most of the people, sir, they are answering D.
Oh yeah, that's good. That's good. So because glucose concentration is available only, so we need another criteria to be fulfilled, not only one, which is glucose concentration. So we will take A1C, HbA1c as well, in addition to the glucose concentration, and then we now have 2 different criteria, and these criteria could be checked from one sample or 2 different samples. So after meeting 2 diagnostic criteria, now we can consider that the patient is, based on the results of HbA1c, that the patient is having diabetes or not, and should we initiate the treatment or not. So let's classify pre-diabetes. So in pre-diabetes, the patient is not diabetic yet, but the patient is, the situation is worsening because impaired fasting glucose is between 100 to 125 mg per deciliter, and this patient can progress to diabetes. There are chances that this patient can progress to full-fledged diabetes. And impaired glucose tolerance, 2 hours plasma glucose after 75 gram of oral glucose, that is 140 to 199 mg per deciliter, and HbA1c is between 5.7 to 6.4%, then we can say that this patient is pre-diabetic. And in pre-diabetics, because we already said that this patient could progress to diabetes, so yearly screening is very important, that you screen such patients who are pre-diabetic at least yearly to see if the patient has progressed into type 2 diabetes or not. Goals of treatment in diabetes: the primary goal is to prevent or delay progression of long-term microvascular and macrovascular complications. So most of the people, they think that the primary goal of diabetes is to just control the glucose levels. but this is not true. The primary goal is to delay the progression, to prevent the progression. Obviously, that is related to the glucose levels, but the long-term microvascular complications and macrovascular complications are actually deadly in diabetes. For example, retinopathy, neuropathy, nephropathy, uh, for example, cardiovascular disease or peripheral vascular disease. So they are actually the cause of increased mortality and morbidity in diabetic patients. So the primary goal is to prevent or delay the progression of long-term complications. And additional goals are definitely to alleviate symptoms of hyperglycemia, minimize hypoglycemia and other adverse effects, minimize treatment burden, and maintain the quality of life of the patient. So these are the glycemic targets which you should aim in a patient with diabetes. So American Diabetes Association recommends that A1C levels should come under 7%. Fasting plasma glucose should be around 80 to 130 mg per deciliter in diabetes patients. Postprandial glucose should be less than 180 mg per deciliter. If the patient is having a continuous monitoring of glucose, then you can also find out the last two parameters, that what time the patient has remained in glycemic range. So the patient should remain in the glycemic range for 70% or greater time, and below range should be less than 40%. So if the targets are not achieved or the levels are uncontrolled, so you should evaluate these parameters after every 3 months. And if there is control on the glycemia, then the patient can be evaluated after 6 months. So evaluation time is based on whether the glycemic control has achieved or not. American Association of Clinical Endocrinologists has slightly different recommendations, but I don't believe you need to memorize those. I think for exam point of view, only American Diabetes Association recommendations are enough. So this is a 96-year patient who has diabetes and hypertension. A1C is 7.5%, sorry, taking metformin 750 mg twice, atorvastatin, lisinopril. What adjustment does the patient need? So what do you think? He's already on the medications of diabetes. What does the patient need? So this is, pay attention to the age of the patient. So I will go back to clarify this point. You see, these are the recommendations of American Diabetes Association, in which the target for A1C is less than 7%. Okay, but there is a line written below this that glycemic targets should be individualized. More stringent or less stringent goals may be appropriate for some patients. So what does it mean? कि ये जो अमेरिकन डायबिटीज एसोसिएशन गाइडलाइंस हैं, ये कोई पुरानी आसमानी सहीफा नहीं है, ठीक है, कि आपने 7 पे जो है वो बस लकीर खींच दी कि 7 जो है that is the goal, and everything beyond 7 we should drag it below 7. So okay, so these guidelines could be made more stringent or less stringent based on the patient. So
how are you, sir? What happened?
Hello, any problem? Can you hear me?
Sir, they are answering B.
Okay. Okay. So they are answering B or D?
Sir, B.
B. Okay. So here you go. So this is the problem. As we already said that uh, this uh, this target can be individualized. This could be made more stringent or less stringent. So in this case, we will make it less stringent because of the age of the patient. Patient is too old. For this patient, even 7.5% is good to go. We don't need to do anything. If we will do something, some other thing would go wrong. Okay, so in this case we will make the criteria, the target, a little less stringent, so we'll accept 7.5. ठीक है, तो ये जो है कोई ऐसा नहीं है कि बस आपने 7 पे लाइन रख ली है और अब आपने जो किसी को नहीं छोड़ना, ठीक है, 7 से नीचे ला के छोड़ना सबको. So you can make it more stringent or less stringent based on the patient. So in management of insulin therapy, which is mostly in all of the cases of type 1 diabetes is required, and in some cases of type 2 diabetes as well, you should be aware of the categories of insulin. So इस table को जो है ना वो रटा लगा लें, ठीक है, which insulins are rapid acting, which ones are short acting, which ones are intermediate acting, and which ones are long acting. So this is very important. So I will not repeat this. You can see in the workbook. So in management of insulin therapy, one of the important consideration is to estimate total daily insulin. Mostly the physicians and the pharmacists, they estimate total daily insulin based on weight. So the total daily insulin, because you have to administer insulin to the patient, so you should be aware what is the total daily insulin requirement of the patient. So on the basis of weight, that is approximately 0.3 to 0.6 units per kg per day. So this is the total daily insulin requirement of the patient. Again, this range could increase based on the patient conditions, but we are not going into the detail. For example, if the patient is undergoing diabetic ketoacidosis, the requirement would be different, so and so forth. But typical range is 0.3 to 0.6 units per kg per day. And what you can do is, this is one of the ways to manage insulin therapy, that 2/3 of this total So 2/3 of this insulin would be administered before the morning meal, and 1/3 of this total daily insulin before the evening meal. So you have to calculate total daily insulin, then you have to administer 2/3 before the morning meal and 1/3 before the evening meal. And 2/3 of the which you are administering before the morning meal, that can be splitted into 2/3 of this as NPH and 1/3 is given as regular insulin. So this 2/3 would be further divided as 2/3 of NPH and 1/3 as regular insulin. So that's why if you see in the market, there are, for example, 70/30 insulins are available. Okay, and that is 70/30 is approximately 2/3 of NPH and 1/3 of regular insulin. So this formulation is already available in the market. So you just have to take 2/3 of this in the morning and 1/3 of this in the evening. So this is one of the ways of managing insulin therapy if you are preferring NPH and regular insulin. So this is one of the ways. but this is not the preferred way. I will tell you the preferred way as well, which is actually basal bolus insulin. So all patients with type 1 diabetes require insulin, and regimens designed to provide insulin in a manner that mimics normal physiological insulin secretion. So this is one of the regimen which we have discussed, that 2/3 before the morning meal and 1/3 before the evening meal. So one of the more preferable regimen is basal bolus insulin, in which basal insulin is given, which is consistent secretion of insulin throughout the day to manage glucose levels overnight and in between meals. And bolus insulin is given to mimic the burst of insulin in response to glucose raise after ingestion of carbohydrates. So basal bolus insulin regimen would have a basal insulin injection and bolus insulin injections before every meal of the day. So this is the most common regimen for managing insulin therapy. So as you can see here, that there are two levels of insulin. So this burst is actually the bolus insulin, and this low straight levels, these are basal insulin levels. So we want to mimic these basal insulin levels by long-acting insulins, and we want to mimic these boluses by, for example, short-acting insulins. So what about starting insulin dose? So we can take 50% of the total daily insulin as basal insulin and 50% as parenteral insulin. So this is the starting dose, and then we can adjust the dose of insulin based on monitoring of blood glucose levels, continuous monitoring of blood glucose levels. For example, let's see, if a patient is 80 kg and we want to start insulin, let's see, for example, the insulin requirement of the patient is 0.5 units per kg per day. So the total daily dose for this patient would be 40 units. So we will multiply the weight of the patient with the units required. So that would be 40 units. So 40 units is actually the total daily insulin requirement of the patient. And we want to give 50%, we want to give 50% of this as basal and 50% as parenteral. So 50% is 20. So 20 would go as basal and 20 units would go as parenteral. Okay, so because he's not taking only one food, he is taking 3 meals a day. So we have to divide 20 units into 3. So that would be approximately 7 units with each meal. Okay, so this is how, so approximately the total would be 40. So this is how we manage the basal bolus insulin regimen in patients of diabetes. So this is the same question. It is, I think, I took it from the workbook. So there is, this patient is 21 years old patient, given a diagnosis of type 1 diabetes. So let's say the requirement is 0.5 units per kg per day. Okay, so we have to see which is the most appropriate initial dose of rapid acting insulin before breakfast for this patient. So what do you see here? We have already discussed this problem. So just give your responses quickly.
Participants are asking, saying C, option C.
C, yeah, we already discussed that. This is actually almost 7 units before every meal. So before breakfast, it should be 7 units. So after starting, we have to make adjustments based on the monitoring of blood glucose. And you should know what is the goal fasting and postprandial blood glucose of the patient. and you should identify if some problem is occurring, where in the day problem occurs. So for example, if the patient deviates from the goal, where is the deviation? Either it is in the fasting blood glucose levels, or there is in the postprandial blood glucose levels. So depending on that, you can adjust the dose of fasting. You can adjust the dose of basal insulin for fasting glucose, and postprandial for postprandial glucose levels, you can adjust the bolus insulin. So if the problem is in the fasting blood glucose, you have to adjust basal insulin levels. And if the problem is in the postprandial glucose levels, then you have to adjust the bolus insulin levels, which you are giving the patient before the meals. So, and you have to adjust the medication or the behavior of the patient. Sometimes you have to adjust the medication only, but sometimes you have to adjust the behavior of the patient, that what should the patient eat, and if the patient is taking different food, how should he or she calculate the dose of insulin based on the different diet or different carbohydrates or different protein contents or different food contents he is taking. So correction of insulin, if you want to correct insulin based on glucose levels, so this is one of the easiest formula. This is called insulin sensitivity factor. So this is actually milligrams per deciliter of glucose lowering per 1 unit of rapid acting insulin. So 1 unit of rapid acting insulin is reducing how many milligrams per deciliter of glucose. If you want to calculate this, just divide 1800 by the total daily insulin of the patient. So for example, the total daily requirement of insulin for patient is 60. So 1800 divided by 60 is equal to 30. So 30 is the insulin sensitivity factor. What does it mean? It means that if the patient blood glucose is more than is 30 mg per deciliter above the goal, you have to increase 1 unit. And the same would go. For example, if the blood glucose concentration is, for example, 60 mg per deciliter above the goal, you have to increase 2 units. So this is how you increase or decrease the units of insulin, rapid acting insulin, by looking at the postprandial glucose levels of the patient. Oh. I think there are some problems with some of the fonts here, but I will tell you what is this. So let's discuss treatment of hyperglycemia in type 2 diabetes. So in type 2 diabetes, the treatment depends on what is the initial A1C level. If the initial A1C level in the patient is close to the goal, for example, less than 7.5%, then you can initiate metformin as first-line therapy. So metformin is always a cornerstone of diabetes care. So if the initial A1C is close to goal, then initiate metformin, or even lifestyle modification alone are sufficient if the patient is motivated. So actually, this is less than 7.5%. This is just give an example that if A1C is close to the goal, you can just start from metformin. You don't have to add any other medication, and lifestyle modifications are sufficient if patient is motivated. But most of the times, patients are not motivated for adopting lifestyle modifications, so we have to initiate metformin. But if the initial A1C is more than 1.5%, then the target A1C. So target A1C was, for example, 7, but the patient is more than 1.5% of 7. So then one medication would not be sufficient. We have to consider 2 medications, metformin plus a second agent. Which second agent? This depends on many factors, which we will discuss in the next slide. Which second agent could be added with metformin. And if the A1C levels, they are very high, they are more than 10% of the goal, then definitely we should consider insulin addition as well. So in this case only, in the third case only, we need to consider addition of insulin in the treatment of type 2 diabetes. Otherwise, in the first two cases, in the first case, only metformin is enough. In the second case, metformin plus a second agent is most of the times enough. But in the third case, we have to add basal insulin. We have to initiate early. So which second agent should we consider? In this case, which second agent should we consider? This depends on many factors. So if there is no comorbidity, that means there is no risk of atherosclerotic cardiovascular disease in the patient, there is no heart failure, there is no chronic kidney disease, then we have to see what are the choices for the patient. So for example, if you want to prevent hypoglycemia in the patient, you should add an agent which has minimum hypoglycemic adverse effects. Okay, so for example, DPP4 inhibitors, GLP-1 agonist, sodium glucose receptor transporter inhibitors, thiazolidine diones, they have less hypoglycemic adverse effects. So we can add these agents with metformin if we have to minimize hypoglycemia. On the other hand, if the concern is to minimize weight gain or promote weight loss, then definitely we have some other options. For example, GLP-1 agonist, they are very good to reduce weight, or sodium glucose transporter 2 inhibitors, they do not have any weight gain. So we can consider these agents. Otherwise, because sulfonylureas, insulin, and thiazolidine diones, they can increase weight. So if the concern is weight gain, you should not consider these. Okay, and if cost is a major issue, which is an issue in developing countries like ours, but for most of the people in developed world, they don't have a cost issue. So if cost is the issue, definitely sulfonylureas and thiazolidine diones, they are much cheaper than the newer agents. So you can consider those. So this is only if there is no comorbidity in the patient. But if the patient has comorbidities as well, then the choices of second agents, they change. So for example, the patient has established atherosclerotic cardiovascular disease, then the preferred agents are sodium glucose transporter 2 inhibitors, for example, empagliflozin or GLP-1 agonist. If the patient has heart failure, then definitely sodium glucose transporter 2 inhibitors. If the patient has chronic kidney disease, again, sodium glucose transporter 2 inhibitors or GLP-1 agonist. So these has proven benefits in cardiovascular disease as well as in chronic kidney disease. So they are preferred as second line agents in patients who have comorbidities with diabetes as well. So this is another case, 66-year-old man, type 2 diabetes for 4 years, A1C today is 7.7. He has altered his diet and he states that he has been exercising regularly for months. He's taking metformin, which would be the best choice to help optimize his glycemic control. So he has not able to achieve glycemic control. We have to add some agent or should we add an agent or not? So glycemic control is not there. So that's why we have to add another agent. But we have to add an agent with metformin. We cannot discontinue metformin in this patient. Okay, so the best should be to add something with metformin therapy. And what should we add? It is based on the comorbidities of the patient. So the patient has no comorbidities mentioned here, so we can add sitagliptin over metformin with metformin. Okay, so don't discontinue. Another patient, 55 years old, type 2 diabetes mellitus, taking metformin, A1C is high, so that means the glycemic control has not been achieved. Fasting blood glucose are at goal. After meal blood glucose is 210 to 230 mg per deciliter. Okay, after meal blood glucose is high. He's worried about his weight. So the main concern here is weight and doesn't want any medication that may increase it. So we have to add something with metformin with the concern of weight. So every agent here has an adverse effect or a side effect of increase, not an adverse effect, side effect of increase in weight, except one, and which is actually liraglutide, which is a GLP-1 receptor agonist. Triple therapy sometimes, even with 2 medications, the goal is not achieved. So we can add another agent from another class, and so we can add a third drug as well, and we can add insulin as well. We have already discussed that if the A1C level is more than 10% of the goal, then adding insulin early is most of the times is a necessity. So because of the lack of time, we will not discuss how you have to add insulin, but most of the principles they are similar to the start of insulin, but we have to reduce the starting dose. So we have to keep the starting dose at 0.1 to 0.2 units per kg per day. And we have to monitor the patient. If the patient is not being under glycemic control, even after adding the basal insulin, then either we can add GLP-1 agonist or sodium glucose 2 receptor inhibitors, or even parenteral insulin is an option. So other than medications which are actually affecting the glycemic levels, there are some medications which are necessary in diabetic patients with to prevent the to prevent the complications of diabetes. So for example, you should manage the blood pressure of the patient, and the goal from American Diabetes Association is actually 140/90. Okay, and this goal can be more stringent if there is an existing cardiovascular disease. If the patient has nephropathies, ACE inhibitors and angiotensin receptor inhibitors are preferred for BP management. So you have to consider management of blood pressure in diabetes, because if the patient is diabetic with hypertension, the microvascular and macrovascular complications, they come early. So that's why you have to manage the blood pressure. Same is the case with lipid management. You have to consider the management of lipids in diabetes patients, and antiplatelet therapy is also required for primary prevention in all atherosclerotic cardiovascular disease patients if they are diabetic and have atherosclerotic cardiovascular disease. This is a 56 years old man with recent type 2 diabetes mellitus, receiving metformin, has no other chronic disease or hypertension, or history of cardiovascular disease. BP is 148/78. So you can see BP is beyond range. Pulse is 74, A1C 6.9. Which agent has the most potential to reduce both macro and microvascular outcomes? So the agents given here, which of the one could reduce microvascular and macrovascular complications? So obviously the BP is beyond the goal. So we have to reduce the blood pressure, and for reducing the blood pressure, if the patient is if the BP is 148/78, that is beyond our expected range. So we can add lisinopril in this patient to bring the blood pressure below 140. So in the end, just 2 or 3 slides on obesity. So there are different guidelines on obesity. We will not go into details, but you have to memorize this one, that based on BMI, which classes exist. So normal BMI is 18.5 to 24.9, and beyond 30, the patient is actually obese, class 1, class 2, class 3. Okay, so you can read this from the slides, and even from the workbook, you can read how we classify the patients. So non-pharmacological therapy, including reduced caloric intake, increased physical activity, and behavior modification, is the mainstay of obesity management. But nobody wants to do this. Everyone wants a pill to reduce the weight. So pharmacotherapy is an adjunct for patients who have failed to achieve or sustain weight loss with lifestyle modifications, have a BMI of 30, who have BMI of more than 27, but they have comorbidity as well, weight-related comorbidity, like diabetes or cardiovascular disease. So this is one of the important concepts which has been tested in the exam over and over again, that what is the minimum weight loss expected to continue the therapy. So this is a patient, 55 years old female, BMI is 32, weight is 120. What is the minimal weight loss expected in 6 months to decide the continuation of therapy? So if you are giving one therapy to a patient, because most of these therapies which are used to treat obesity, they have side effects. So in order to decide whether to continue the therapy or not, you have to look what is the minimum weight loss. So what is the minimum weight loss expected in this patient? So the minimum, the range is 5 to 10%. You should see a weight loss of 5 to 10% in 6 months. Okay, so this is the range. The minimum is 5%. So you have to see what is 5% of 120. Okay, so that would be, what would be it? My math is not good. So that would be 6, right? So these are the agents which are available for pharmacotherapy of obesity. But we already discussed that most of these agents, they have okay, so they have their side effects. So in order to continue the therapy, there should be at least 5% of weight lost in 6 months. So that's end of it. Let me see your questions, because during the presentation I couldn't see any. Let me see. That's good. Sumaya is very active, giving answers of most of the questions. ACE inhibitors, Sumaya is aware. Next time, Sumaya should deliver the lecture next time. She is very good. Anyways, 20 minutes, okay. So there was some problem with the screen sharing.
In the start, but it's fine. It go well. I don't think so there was any issue.
Okay, I will share the slides as well. Just go through them again if you want.
Apparently, I don't think so there is any question, but if still the participant have any question, they can ask in the group as well.
Yeah, they can ask
Okay.
in the group, or they can send an email to Dr. Kamran or the moderators. So I think it's too late in Pakistan at the moment. So,
Yeah.
and In winter, everyone is feeling sleepy now, so you should go sleep now.
I guess there are few questions in the top of the chat box. We can share it in the group as well. Dr. Ammar, are we going to take the questions for now, or we shall discuss them in the
Yeah,
group?
I am here. I don't have access to your group, I think. But if you have,
Okay.
if some participant has any question, I am here for a few minutes.
Yes, I'm reading for you. Dr. Mehreen Muzammil is asking that please share some PTU takes 4 to 6 weeks, how thyroid storm will be managed by it mechanism. Participants, you may open your mics now if you want to interact with the lecturer. So you may open your mic and speak yourself.
Rida, may I elaborate the question that you read just?
Yes, ma'am.
Actually, it was discussed that PTU takes around this much time to give some effects. So, if the patient has thyroid storm, how PTU will manage the patient? How PTU will affect the patient? What will be the mechanism for that?
Yeah, actually, PTU is better than methimazole. It has an early onset, and it also prevents the peripheral conversion of T4 to T3. And T3 is actually the more active form of thyroid hormone. So by preventing the conversion and somewhat early onset, propyl thiouracil is more effective than methimazole in thyroid storm.
Okay, thank you so much.
But actually, Mehreen, I think it was Mehreen.
Yeah.
You would not be. You would not be. This is good for your. I mean, personal progress. But such concepts, I don't think they would be tested in the exam. In exam, you would be tested for more important and basic concepts. Okay, so these concepts, why one is, for example, preferable over the other mechanistically, this is beyond the scope of this certification exam.
Okay, thank you.
Yeah.
Okay, so Dr. Anam is asking that RAI is better for 12-year child.
For 12-year child, I think there is no contraindication in children. He can or she can undergo radioactive iodine ablative therapy.
Also, she is asking that for hypertensive patient, what will be drug of choice for obesity? Hypertensive or okay. So
Hypertensive patient.
I don't think so. It will be hypertensive. If Dr. Anam may correct it, what does she actually want to ask? So Dr.
Usually, yeah.
Sumaya Zubair is asking that in previous case of age 60 years, strict glycemic control was discouraged on 7.5 HbA1c. But in case 9 with 7.7%, why another agent was added at age 68?
Let me see the case 9 and let me see what that's a very smart observation. Let me see case 9. Case 9. Previously, we discouraged on the age of 96, not 60. Are you sure we discourage at 60? At 60, we don't have any problem. At 96, the patient is too old to do some adjustments. So Maya, check it again. I think the patient was 96-year-old in which we make less stringent the glycemic control.
Okay, sir, I think so we should wind up the session. It's already too hectic for Dr. Ammar.
Answer was do nothing. It was using that case. I didn't get it, Sumaya.